I think just to say I have nothing to disclose or no conflict. So just going over mitral regurgitation. We all know mitral regurgitation leads to more mitral regurgitation, and if patients are untreated, mortality can be up to 57%. So every patient being treated for mitral regurgitation, this is what we have, that we know when surgery was a treatment for mitral regurgitation, we know more than half of the patients were not getting surgical treatment. So just to go over the classification of mitral regurgitation, we have two kinds. One is primary, where we know the pathology is all anatomical with the leaflet, subvalvular apparatus, and chordae papillary muscle. This is a primary mitral regurgitation. And secondary mitral regurgitation is that there is some problem with the LV. For whatever reason, the LV dilates, and that gives rise to mitral regurgitation leading to left atrial dilation, and so on and so forth. So what are the prognostic determinants of mitral regurgitation? Very simple: severity, left ventricular function where we are, and of course, symptoms of the patients. So there is ACC guidelines to say how a decision has to be made in the diagnosis of mitral regurgitation as well as in treatment of mitral regurgitation. So when a patient presents to you, the question comes, how do we identify? What is the first tool that we use to diagnose mitral regurgitation other than stethoscope? Is definitely echocardiogram in the primary care, or whether they're doing in cardiologist's office. Then you can define what's the kind of mitral regurgitation, but more important is after that you have to start some kind of treatment, which I will go over who should get what kind of treatment. But once you have started treatment and then you're referring to tertiary care center, and a tertiary care center is where what we discuss about a heart team. The heart team will include a cardiologist, could be a heart failure physician, interventionalist, as well as a surgeon. They are the one who are going to do several other tests, and one of the most important tests to be done will be a transesophageal echocardiogram. This is the one that's going to tell us, is this something that can be treated percutaneously or something that cannot be done, has to go for surgery. So just the basic principle in treatment of mitral regurgitation is very simple. When it's primary, we know medical therapy does not work, and over years it has been shown that surgery is the treatment for primary with or without symptoms in this kind of patients. Now, coming to secondary mitral regurgitation, which probably is the discussion here today also because of heart failure patients. These patients need medical therapy first, depending on what kind of therapy that has to be started, whether it's a beta blocker, ACE, aldactone, diuretics. Then goes to treatment of other associated condition with them, which could be a CRT, or if they're in atrial fibrillation, treatment of atrial fibrillation also is the key. And after that, if they're still symptomatic, that's a time we come into picture. And we know surgeons usually do not like to take care of these patients, and outcomes are not good when it is secondary MR. Just going back to the primary MR, how did a clip first was approved by FDA was based on this trial, AVREST-2, which was a randomized clinical trial for patients with mitral regurgitation. The randomization was 2-to-1, where the device group was mitral clip and the control group was surgical repair or replacement. So if you see that, echocardiographic as well as clinical follow-up up to 5 years. So what did the study show? Of course, compared to the control group, the device group was safe. Whenever there is a new device that's out there, the first thing and foremost everybody wants to know, is the device safe? Yes, device was definitely safe, but we know it was not as effective as surgical treatment was. But if you see here at follow-up at 12 months as well as later on, that 3+ mitral regurgitation, though we saw 3+ mitral regurgitation in patients who received a clip, if you'd see NYHA functional class, that NYHA functional class, even in patients with the 3 plus mitral regurgitation was very low, just telling us that medical therapy continued on these patients, and then they were not symptomatic, even though they had some residual MR. So this was freedom from death, MV surgery, or reoperation after the landmark analysis, that after the first 6 months that there was no difference between the two arms. So based on that, the clip was approved for primary MR. So just to show you a case, this is a 79-year-old female who had dilated cardiomyopathy as well as multiple other comorbidities, presented with dyspnea, orthopnea, PND, the usual heart failure symptoms. So limited and was on good therapy. So if you see your echocardiography is severe mitral regurgitation, both on the left and on the right, you see the 3D where you see restriction as well as some prolapse of the anterior leaflet. So, this clip is done percutaneously. It's a venous procedure where we have to do transeptal and go to the left side and then place the clip. So once we place the clip and before we release the clip, we always check for, how good the clip attachment is as well as the residual gradient. So if the gradient is acceptable, we keep going till we make sure the regurgitation is almost minimal. And we'll tell you why we want to make sure the MR has to be minimal. As you see here, you're almost to minimal mitral regurgitation, and on the 3D you can see the 3 clips that were done in this particular case. We also do simultaneous, but it's through the same sheet that we can record the V waves. So we see the V waves at baseline as well as the V waves after 3 clips that almost less than 20 millimeters there. So outcome of transcatheter mitral valve repair based on what we say is a registry, that all these patients, whether they're getting aortic valve replacement or mitral clip, they are part of ACC STS registry here. So based on the registry, you can see what are the overall outcomes. So acute procedural success of the clip is over 90% or so, with in-hospital mortality of 2.7%. But more important also is that you see here death, heart failure, or in-hospital revascularization is very less. So the mean age was about 82% or so, or STS median on this patient was about 6%. What did this TVT registry show? That these patients, whether they are functional or the primary MR, their outcome was better when follow-up even over an year. So post-procedure mitral regurgitation, like I mentioned, why we have to go and make sure that you have to reduce the MR to less than 1 plus or so, is your outcome is based on the residual degree of mitral regurgitation. So if you see here, patients with grade 3 MR had poor outcome compared to grade 1. And another important thing also, severity of TR, that if patients who had residual tricuspid regurgitation also did poorly when they had followed up. Moving on to secondary mitral regurgitation, 2 important trials that actually published back-to-back in New England Journal, which I'll discuss shortly. One is the CoOp, the other one is the MITRA-FR trial. What was the MITRA-FR study design? Now this trial was done in Europe, that again was evaluate the clinical efficacy as well as for percutaneous mitral valve in addition to the medical treatment of this patient. And primary endpoint was all-cause death or unplanned rehospitalization for heart failure at 12 months. So the enrollment and randomization is the key between the 2 trials. So if patients had mitral regurgitation, they were enrolled in the trial, they got either the therapy or which is mitral clip, or they were randomized to just medical therapy. Patients who got clip were then put on medical therapy. So what did we see in this? That, of course, success was 96%, which we said earlier also is more than 92% or so is the success rate usually in the clip. 1, 2, or 3 clip. You see the most majority of the patient, you would say you've got 1 or 2 clip, and 3 clip maybe less than 10%. So if you see the clip arm versus the control arm, there was no difference here. And we'll say the reason. The reason is for mainly because patients went on therapy, which is medical therapy, as I discussed before, after getting the clip. So this is the Kaplan-Meier curve saying no difference in survival primary outcome at 1 year. Compared to the MITRA-FR trial, what was the difference in CoOp? One, it was done in United States. So 1-to-1 randomization happened after patients were on guided medical therapy. And we'll say what the guided medical therapy was. So they had to have mitral regurgitation, which is secondary mitral regurgitation, moderate to severe. Had to have symptoms on medical therapy, and then they were randomized to clip plus medical therapy and just medical therapy alone. This was the randomization, and the 2-year was followed. So just to show you that patients on therapy had to have hospitalization, they had to have a BNP about 300, so the very strict criteria to get into this trial. So if you see here, the average age, about 70 or so, and patients had multiple comorbidities, diabetes, hypertension, prior MI, PCI, CABG, TIA, and look at the BNP of these patients. They were over 1,000, essentially saying that, true heart failure patients who needed and they were on this therapy. So NYHA class also was the same, is 2 or 3, majority of the patients, and you see the echo, they were, EF as well as ED, what I would say, the measurement was also larger LVs. Most of the medications, beta blocker, ACE inhibitors, your mineralocorticoid receptor antagonists, diuretics. So if you see, they were on this therapy. Then comes, did this patient continue the medications? So majority of the patients, everybody, continued the medication. The discontinuation rate was very little in this group. So what was the outcome? The procedure of the mitral clip itself. So what we showed, less than 1 plus MR or 1 and 2 plus MR was achieved in over 92% of the cases. And if you see, majority of the patient again got 1 to 2 clips, and one patient even got 4 clips in this. So since it was a very strict criteria, the outcome we saw was totally different. The primary outcome was all hospitalization for heart failure within 24 months was significantly lower in patients who got clip and continued on medical therapy. And same thing, that the all-cause mortality was lower, first time showing that a clip really helped in this secondary MR patient to even decrease the mortality. This is a combined death and heart failure in this group of patient. One other thing that they also showed was that patients with heart failure who got clip compared to medical therapy, the need for LVAD and transplant was also lower in this group of patients. Based on that, we know there is a new trial that they're doing. Patients who are waiting for LVAD, that they will be randomized either to medical therapy or clip. So why these two trials are different outcome? One is CoOp as well as the mitral FR. Why did they have different outcome when it came to hospitalization and mortality? And I think the important difference is how the patients were actually picked and who got the treatment. Like I mentioned, if you see in mitral severe MR in the MITRA-FR trial, they were really dilated LVs with severe MR compared to CoOp, where severe MR was there, but LV was not badly dilated. That's number one. Number two, medical therapy was first tested on this patient, and people who failed medical therapy, we know most patients respond very well to medical therapy. When medical therapy failed, they are the one who went on to get the clip. So we all know this is another term that has been there and discussed since then, is proportionate and disproportionate mitral regurgitation. and this is where we are with the discussion of the same, that patients in CoOp, if you see here, had disproportionate mitral regurgitation compared to mitral FR, who actually got, who were severe MR on proportionate MR. So after this trial, which is a CoOp, mitral clip got FDA approval for secondary mitral regurgitation patients also. There's another trial that's ongoing in Europe, which is a Reshape, again with same mitral clip versus secondary standard of therapy for FMR. Another analysis that came out from the CoOp that was presented in TCT of 2019, that what happened to the patients who actually were crossed over, who were on medical therapy but crossed over and got the mitral clip. So if you see here, all-cause mortality in patients who were actually crossed over, which was the orange line, they did very well, like they had got mitral clip, which was the blue line there. And this is all-cause mortality as well as the heart failure, combined everything. So based on those two trials, and now that we know the FDA has approved this device, actually the recent JAC, which was in 2020, that came out with certain guidelines that who should be doing it and which centers should be doing it. These trials, these are the overall centers, and every operator requirement is there, as well as the site requirement for these procedures to be performed so that they're done appropriately. So we just changing the gear a little bit to say, just going on with the mitral valve disease itself, that what happens if somebody has had a mitral valve replacement in the past, and then now they have a failure of that mitral prosthesis. Is there something we can do percutaneously? So this is a 77-year-old female who had a 25 millimeter Hancock prosthesis mitral valve replacement in 2003 for a degenerative mitral regurgitation. And now she presented with the recurrence of symptoms. But if you see, she had severe COPD and, petite patient. So she was felt too high risk for re-op. So is that something we can do? Yes, we can do the same way, the transeptal, and then get into the left ventricle and place a TAVR valve into the mitral prosthesis, which is what we can do here. So this is the TE showing us that it's failed. There's a stenosis as well as a regurgitation of this valve. So what you're seeing here is the Sapien, which is actually a TAVR valve that is in the mitral position, and we are inflating. In the mitral position. So this is how the final angiographic result. But more important is, if you see here, the gradient that was 19 went down to 7, and this is the prosthetic leaflet with the fully functioning valve now. So that was before, and now you see after we replaced it with the Sapien valve, you see a fully functioning another prosthetic valve. Coming to the native valve, that if you have a native dysfunctional mitral, which could be mitral stenosis or a dysfunctional mitral valve, we discussed about the clip. Can we replace it with a valve? Since compared to aortic valve, anatomy of the mitral valve is very complex, and that is why you see that there are over, I would say, 12 designs of the valve. Also, you see that even if you place the valve, there is various, its anatomy is very complex, so it's not that easy. So the most important thing we as interventionalists are worried is LVOT obstruction from the new valve that is placed at the mitral position, and rarely it can embolize into the left atrium. Because of this challenging technique, you see here, these are the current devices that are available, but there is a registry which has reviewed this various valve, and of course the outcomes, we know the midterm clinical outcomes are reasonable, but there are several based on this registry data and couple of, man in device. This device has been approved, which is an Abbott tendon valve, has been approved in Europe, but the trial is ongoing in United States, has not been approved in the United States yet. So just to conclude, we know the mitral clip is a good therapy. FDA approved both for primary MR, is a good therapy for secondary MR, provided people are on good medical treatment. And again, I have to emphasize that anatomy has to be feasible for the clip. Anatomy has to be feasible in primary MR as well as feasible in secondary MR. So if there is a dysfunctional mitral bioprocesses, yes, we can do it percutaneously by placing the SAPIEN valve. And of course, for the native valve, the several trials are ongoing, and we will know in the near future whether it is possible or no. I know this teaching now has become virtual, but we started teaching how to do live cases and all the tips and tricks 12 years ago. Even before anything. And then this is where we are with all this, we are on a YouTube channel where we can see us doing live cases and teaching people with regards to intervention as well as structural, as well as peripheral, Facebook, Twitter, all these things. And just to tell you, we are also have several apps for the interventional cardiologist to learn how these various techniques can be done. Is on the apps now. So thank you for your attention.